What's going on, everybody? Welcome back to another week of AJ's views on orthopedic surgical considerations. This week, we are going to be discussing the modified Brostrom procedure for lateral ankle instability. We know that ankle injuries are very, very common, not only in the world in general, but also specifically in the state of athletic training. They account for almost 2 million injuries per year, around 2.9 per 1,000 athlete exposure. So that's a lot, right? So that we talk about. So this procedure, the purpose of this procedure is to reconstruct the torn lateral ligaments complex in order to obtain and provide a stable ankle joint. So the lateral ligaments of the ankle that we know of are the anterior ATFL ligament and as well as the CFL ligament. As well as we're going to incorporate this in terms of the retinaculums as well. We want to discuss. Sometimes you can even consider PTFL in this, but this procedure does not discuss or take care of the PTFL. But we know that the PTFL ligament can be also disrupted or injured in a inversion or lateral ankle sprain. So, what are some indications of getting this surgery, right? So one of the main indications is lateral ankle instability, right? You are that type of person where your lateral ankle isn't stiff, or isn't stable. It rolls a lot. You walk and then all of a sudden it rolls. And the next indication that is something to think about as an athletic trainer is failure of conservative management for this chronic ankle instability, right? This is what we've tried taping, we tried bracing, and we tried rehab, and nothing has worked. So our last resort here to get this patient feeling a lot better is for them to have this procedure. So what is some potential complications of this procedure, right? So first, obviously, any procedure will have potential blood clots, a potential DVT, potential rate of risk of infection. But some things I really want to note here is potential nerve damage, right, or potential nerve injury, right? We are reconstructing the lateral ligaments of the ankle, so there's going to be some issues here as we try to maneuver around, the retinaculums, move around veins, arteries, even nerves. There could be some damage to a potential nerve or some type of injury to a nerve that creates persistent pain, right? That's another potential complication from the surgery. And lastly, potential peroneal or perineal, however you decide to pronounce it, perineal or peroneal tendon irritation or injury, right? In some forms of this procedure, the perineal tendon, especially the perineal brevis tendon, is sometimes reconstructed as well, along with the retinaculums being shifted a little bit to help provide a little more stiffness. So we're going to talk about the steps of the procedure, right? So how does this procedure work? I'm going to give you some steps. How this procedure works in general. There's some great literature out there to discuss the step by even in more grave detail about how this procedure works. So the first step here is the surgeon will perform a distal and incision over the distal anterior border of the lateral malleolus, right? So they're going to make that incision there, and then they're going to identify a couple key structures here. They're going to identify the extensor retinaculum, the ATFL ligament, and the CFL ligament, right? This is after they've kind of cut through some fascia, cut through some fat, cut through the skin, kind of open things up with the retractor. They're going to look to identify those key structures. Third, the ankle is then placed in a valgus and dorsiflex position. From there, what happens is sutures are then passed through the proximal edges of the ATFL and the CFL ligaments. Then holes are drilled in the distal fibula, and then the sutures are then passed through those holes and are tied and fixated in order to reconstruct the lateral ligaments of the ankle. The next step is extensor retinaculum that I mentioned in the beginning is used to help reinforce the repair. So it is kind of moved a little bit. Just the proximal edge, the posterior proximal edge is moved slightly in order to add some increased stiffness. But this also helps limit eversion in the ankle. Then sometimes, as I mentioned earlier, the peroneal brevis tendon can be transected proximally, and then the surgeon will drill a hole through the distal fibula, and then that peroneal brevis tendon is then passed through that hole, and then it is then tied and tensed down with the foot in plantar flexion and eversion. Okay, so normally I'll usually at this stage I'll talk about more about research, and the research here is important, but I was really interested this week in discussing more the rehab, right? Talk about post-op rehab and kind of what the literature is saying out there, and seeing what type of protocols and what those protocols call for with a surgery like this. In my experience, I've had one athlete have a surgery, and I've known a few other people who have had this surgery. I consider having the surgery myself because I do have some chronic ankle instability personally. So let's talk about the rehab, right? And rehab is really important here. So depending on the surgeon, this is surgeon dependent. One of the articles we read this week, the surgeon allowed the patient to be partially weight bearing in a boot right after surgery. Others decided to do a cast or a soft cast. And so one of the other literature articles I read by said, hey, we are a soft cast for the first week and the first 2 weeks. At a follow-up point, we're going to switch to a boot. So phase 1 of this rehab protocol is from 0 to 2 weeks. And some key things here are protection of the repair, edema control and reduction. We want to limit and reduce edema following surgery. It's one of the things you definitely want to do when you're considering someone's having surgery or any type of injury. The next thing is the patient needs to be non-weight bearing via crutches or scooter, whichever the patient end up preferring, or the surgeon ends up preferring in that case. And then certain protocols are allowing for hip strengthening and core strengthening to be started. This is kind of low-level stuff, doing some quad sets, doing some knee, doing some TKEs, small stuff, nothing too crazy, just to get the quad going, just get that hip going, so that we're trying to work on some strengthening stuff here. Phase 2, right? This is around 3 to 6 weeks. You can begin restoring dorsiflexion, plantar flexion, and eversion, not avoiding inversion. Partial weight bearing can be started with an assisted device, if that's going to be like a cane or potentially one crutch, or in a walking boot. Those are some things that you can start. Then we want to continue hip and core strengthening and maybe advance out a little bit. Phase 3 is looking at 7 to 8 weeks. You want to really begin or continue restoring gait pattern, right? We want to get this person be able to walk properly, hopefully at this point without a boot, or in the boot during rehab, out of the boot during rehab, in the boot for walking long distances. We also want to start incorporating the bike for cardio, maybe some pull work to help with the rehab situation, and start doing some joint mobs, also working lightly on the calf, right? Can be doing some seated calf raises, maybe some seated isometric calf holds, start that general ankle strengthening. Phase 4 is looking at 9 to 12 weeks. This is where we want to really start our balance and proprioceptive work. Maybe start doing some full body, especially full lower body strengthening. Start to work on single leg balance. Start working on some single leg strength. Phase 5 is that 3 to 4 month range, and this is where you really want to continue that single leg progression, right? Start maybe doing some single leg hopping. Start doing some single leg bounding. Start doing some single leg calf raises. Start doing a lot of things some single leg squats, and then also progressing to a lunge progression as well. So doing forward, lateral lunges in different sequences. Phase 6 is used at 5 to 6 month range plus. This is where you're working on agility and plyometric progression, also including some running program, and start to introduce some sport specific drills. At this time, this is where you really want to maybe utilize a handheld dynamometer or another tool to be able to assess strength before you're about to clear an athlete to go back to go back into sport, or start practicing, start doing drills with the team, just so you have some type of numbers to measure. Hey, we're measuring all 4 ranges of motion for the ankle, and also measuring some other things as well. So again, I know this is a quick, a little different than what I've done in weeks past, but I hope you guys enjoy, and stay tuned for next week. Y'all be blessed.